And we would like to thank Charles James for being on the line with us today. He has very graciously taken some time out of his schedule to talk to us about provider-based rural health clinics. And I will go over questions at the end there, Charles, but in the meantime, I will hand it over to you.
Excellent, Allie. Thank you very much, and a generous introduction, because we're here today, in effect, because I messed up my schedule very badly for the wonderful presentation and conference that the RHA and Tina Elliott put on. So I horribly messed up my schedule. It was all me. It was all Charles James. That's why we're here today. I appreciate the IRHA for still talking to me and allowing us to have this session today on provider-based rural health clinics. So obviously that is our topic, and if my controls will work for me, these are the areas we're going to talk about today. So I want to go over just some brief and very basic definitions for some of us who may not already know some of these terms. Maybe some of us that are new to the hospital environment. I'm going to talk about a reimbursement comparison. And then my main thrust for this presentation is I really want everyone to be able to get a handle on what are our criteria for being provider-based, what are maybe some of the differences with those criteria for off-site locations, and frequently with so much of our hospitals having taken over clinics, we often want to have configurations with leased employees and management contracts, and we want to talk about what the parameters for those are, as well as what some of the penalties would be for non-compliance with your provider-based criteria. So first, our definitions are really just the two basic hospital types that we typically see with provider-based clinics. And the first of those would be a PPS hospital. That's a payment system for short-term acute care hospitals. Most of our hospitals that own rural health clinics are either PPS hospitals or critical access hospitals. I think that most of us are familiar with the differences between these two types of entities. Our critical access hospitals, of course, is a little bit like the rural health clinic program for hospitals, and we get 101% of our reasonable cost under a critical access hospital, where PPS hospitals are effectively paid on a fee schedule. So there are some differences between really some of the exceptions that are enjoyed. A couple of the exceptions that provider-based rural health clinics enjoy are based on their association with a critical access hospital. And some of these exceptions we enjoy as provider-based rural health clinics are by virtue of us being associated with a hospital of fewer than 50 beds. So certainly we can have a PPS hospital fewer than 50 beds, and by their nature, critical access hospitals are fewer than 50 beds, and I believe their limit is 25. So just a little bit of the differences between the two types of entities. And ultimately then, what is a provider-based rural health clinic? I think that out of the box, the term provider-based confuses a lot of us, so that we infer provider-based really not being hospital-owned, but provider-based refers to a hospital-owned entity. So our provider-based rural health clinics are those that are owned and operated by a parent entity, usually a hospital. Now, other entity types can own provider-based clinics, can own provider-based rural health clinics, but only a provider-based rural health clinic whose parent entity is a hospital. So provider-based rural health clinic with ownership by a hospital of fewer than 50 beds is eligible for our uncapped rate. So part of the main reason we put our rural health clinics underneath our hospital is so that we get uncapped reimbursement in our provider-based rural health clinic that is only available to a rural health clinic, provider-based, associated with a hospital of fewer than 50 beds. The reason I keep emphasizing this is I always get the question, can a home health agency or a skilled nursing facility own a provider-based rural health clinic and get the uncapped rate? The answer is yes and no. A home health agency or skilled nursing facility can own and operate a provider-based rural health clinic, but that provider-based rural health clinic will not be eligible for the uncapped rate. That is only available to a hospital with fewer than 50 beds. There's a lot of talk right now about the new PPS proposed rule that is out in some stage of being finalized. And so I probably just stepped all over that term. I believe there's a proposed rule out there that is in the process of being finalized this fall. I could have some of those dates wrong or the status. I believe it is still a proposed rule. I don't believe it's been finalized. That has to do with a PPS system for provider-based clinics. I've been getting many calls from our hospital CFO folks concerned about the new PPS rule and its effect on rural health clinics. What I can tell you is that one of the exceptions that rural health clinics enjoy is that for the purposes of their provider-based status, rural health clinics are not a department of the provider. In this sense, the provider is the hospital. So all of the language out there about the PPS system relates to departments of the main provider, outpatient departments of the main provider. So provider-based entities, provider-based rural health clinics, we are absolutely an integral part of our parent hospital, probably a critical access hospital, maybe a PPS. We're integral parts of that. We function in all manner as we were an outpatient department of the hospital. So that's how we function. We're subject to the same personnel rules. We're subject to the same organizational structure as our parent hospital. We're subject to the same reporting requirements as our parent hospital. We're going to talk about all that. But as a rural health clinic, we are not a department of the hospital. We are a facility. So because we're not a department, so there it is, 42 CFR 41365, we are not a department of the provider for the purposes of this section. So we get a pass on all the PPS stuff that relates to outpatient departments of the hospital. Now, this is all important because there's a big financial difference for provider-based rural health clinics. Provider-based rural health clinics, independent rural health clinics right now in 2016 are capped at $81.32. I really see that this independent rate is going to get some attention. In addition to our provider-based rates that on average we see between $140 and $167. That's an average. That's a pretty sweet deal, even if it's a fairly low provider-based rate is $140 to $167. Now that's not scientific, that's what we see, but I think that the national data that's out there supports that. When I say that these will get attention, the provider-based, the independent rate is really artificially low, and I could give you reasons behind that that are fairly boring, but it has to do with when and how the base rate was set when the program was established. Our provider-based rates that we're seeing, the issue is that we're seeing some rates that come out and $250, $300, $350. Now, I can tell you, just like in the old days, the condition of our paper chart rack being a barometer or a good indicator of what the facility compliance looks like, a really astronomical rate like that is a negative barometer. That is a negative indicator that there's something wrong in that practice. So while a $350 rate may be great, it means you have an expensive physician seeing no patients is likely what that means. So those astronomical rates is where I think, this is Charles James speaking, not on behalf of anyone but my own crystal ball, that I think we'll see some moderation on how the independent rate gets set, and I think we'll see some moderation on those really astronomical caps. The policymakers are out there asking the question, hey, why is it that when a rural health clinic flips their shingle that their rate doubles? It cannot be inherently worth double by flipping their shingle, all things remaining equal. And we all know that the difference is allocation of hospital overhead. So that's really where the rate differential comes from. When we remove the hospital overhead allocation, the rates equalize a bit. So my only point is there's no formal move underfoot. We see these averages out there. I think that will ultimately get some scrutiny. And people always ask how long the program's going to be around. People have been asking me that since 1990. And I think the program will stay in effect. I think that we'll see some moderation on this rate setting. So whoever I'm making mad about that, I'm sorry. That's my own personal opinion. You can have a provider-based rural health clinic if your hospital is greater than 50 beds. Now, I generally give this presentation to a national audience where I don't like to get into state-level rate setting issues. But I know that generally speaking in Indiana, you follow, or Myers and Stouffer follows the Medicare cost report. So even at the Medicaid level, there's no real financial incentive for a provider-based rural health clinic whose parent is greater than 50 beds to be provider-based. There's a heck of a lot of expense with being provider-based. We have to move the clinic under the whole status of the hospital. You know, if your hospital is joint commission, now the clinics are going to be joint commission. So it's not an inexpensive gig. So generally speaking, there's no financial incentive if your hospital is greater than 50 beds to be a provider-based clinic. Now, with that said, many of us think our hospitals are larger than they are. So our 50 beds is bed availability within 24 hours. There's a little formula in the cost report software that will give that calculation. So it's not licensed beds. I always give the anecdote of a hospital that I pulled up to in a different state, and they had been telling me that this was a 100-bed hospital. And I pulled up and I said, man, to myself, there's no way this is a 100-bed hospital. And indeed, when I dug a little deeper and asked different questions, i.e., what's your daily census, their daily census was more like 14. And I said, okay, well, what's the likelihood that you're getting up over 50 beds? And they said, well, never. So we really want to be mindful of the gauge. It's 50 beds, not 50 licensed beds. And if you have a 100 hospital bed, but you're only putting 14 patients a day in there, there's a big financial incentive on this provider-based stuff. And here it is right here. Here's just kind of a standard example of what a Medicare claim would look like. Of course, Medicaid's just going to pay the straight rate, generally speaking. But for a standard office visit of $100, we have a clinic whose rate is $80.04. So they have last year's rate still on this clinic, which is how these run. I'm not as accustomed to the controls on this presentation platform, but my easy math tells me that we know that Medicare pays 80% of our rate. 80% of the independent rate is $64. Our patient's going to be responsible for $20 co-insurance, which is 20% of the charge. So on this patient, we're going to get roughly $84. On a provider-based patient, the exact same patient for a $100 99213, we have a rate of $160. We have a Medicare payment of 80% of that rate. We have the same patient coinsurance. We don't quite double, but we're about 85% of our total payment under provider base. So we see that there's a big difference here. Now, again, generally speaking, the differential between these two is the allocated hospital overhead, which is perfectly reasonable and perfectly legitimate and exactly how the cost reporting software is set up. But on the face of it, we know that that is what's driving the difference in that reimbursement. So where we look at provider-based status as an independent clinic, you know, often not only does that provider-based status really save the clinic, but a lot of times if it's done right and your providers have got decent productivity and a reasonably efficient operation, hospitals are operating on 2 to 3%. We a lot of times see the 6-digit pickups on these provider-based rural health clinic differentials. So not only saving the clinic, but it can save the hospital. Now, again, on the state Medicaid reimbursement, you all in Indiana, I know that Myers and Stouffer largely follows the Medicare cost report. They've got some of their own cost reporting functions. So they being Myers Stouffer. So for example, instead of just wholesale following the Medicare cost report, Myers and Stouffer will put a differential in on a differential. They'll put a bit of a add-on to the rate. So for example, if your rate comes out to $160, they may put an add-on of $3 for all your lab and pneumo flu shots. So to say that it follows directly from the Medicare cost report is not accurate, but it's certainly derived from the Medicare cost report. So in other states, for example, just next door in Illinois, the rate setting mechanism is very, very different. So we have to be careful in national audiences when we talk about Medicaid, but here in Indiana, we know generally how that cost report is set. So you should get the rate out of both, excuse me. Pardon me, folks, I had to clear my throat there, excuse me. Now, one of the biggest differences with billing is the fact that under provider-based, we deal with our technical components and our lab services a little differently than a regular independent or physician office would. Without going too deeply into billing, we know that our professional components are peeled off from our diagnostic tests, and our professional components are part of our RHC encounter. Further, we know that our technical components, when we peel that professional component off, our technical component is a non-rural health service. And because that's a non-rural health service, we can bill that on a $1,500 fee-for-service for additional payment as a non-rural health service. Now, those additional technical components the additional technical components in an independent clinic get billed fee-for-service using a Part B number. The biggest difference is with provider-based, those technical components get billed out under the parent entity's provider number. So, biggest difference, parent entity's provider number. And I'm going to see if I can draw here. I don't know if I can. Parent entity, oh, that's not going to work. So what I want to do is highlight here, and I'm not going to waste too much time trying to do that. Parent entity's provider number right here is where we bill, and it's still just writing all over there. Technical components, all lab services go under hospital provider number as a provider-based clinic. Hospital provider number as a provider-based clinic. We do not bill these under our Part B group number. These goes on our hospital P10, hospital tax ID number, under the parent entity's billing number. How you get that to happen is a different question, and Medicare will say kind of your own problem. But parent entity's Medicare number, not your medical group. Parent entity. Biggest billing difference right there with provider-based clinics. Now, I've been emphasizing how much, so on the billing issue, I've included some billing parameters in here. I'm not going to go through each of these, but you can see on our provider-based lab claims, if we're owned by a CA, this is the relevant information. So our provider-based lab, and I'm going to try to draw again here. Is it going to work? Our provider-based lab. So here's our spotlight kind of working on there, not really. Type of bill 851, and I just changed my slide. Sorry about that. 851 revenue code 300 on a UB04. That's parent based on the cost report. This is owned by a CA. Same. Here's our radiology technical component claims. Same 851 type of bill, revenue code 320 in this case. And then our EKG claims, everything's the same. Our revenue code changes. Our billing parameters for PPS hospital for all of our non-rural health clinic services. So keep in mind, all of the slides I just showed you are the billing parameters for our non-rural health clinic services, where the payment is cost-based by a CA. The payment is on the fee schedule by a PPS. And regardless, these are non-rural health services. Biggest provider-based difference right there with billing. So just another representation of some diagnostic services and where these get billed out. And let's try it again. Is it going to work? Can I do it? Am I good enough? I don't know that I am. And oh, there we go. Excellent. So our 93005, now that's going to get peeled out, and that's going to be billed on a UB04 using the hospital PTAN number, paid at cost if you're a CA, paid at a line item, fee for service if you're PPS. So there's our biggest billing difference right here, and that's just a brief example. Try to get back to my controls here. Now, with more money, we all know what I like to say is ain't no free money. That's a highly technical term, no free money. We know that with the greater financial reward on our provider-based status is going to be larger risk. So our provider-based requirements can be found in CMS Program Memorandum A03030. And this document really is a summary of 42 CFR 413.65. 42 CFR 413.65 is the reg, the Federal Register, federal regulation for provider-based clinics. Delineates requirements for on-campus and off-campus, and everyone needs to know that for our purposes, off-campus is more than 250 yards from the hospital entrance, from the main hospital entrance. 250 yards, you can Google it. But if it's 251 yards, even if it's down the street, you have an off-campus provider-based clinic. There's some different requirements for on-site, on-campus versus off-campus. We report all of our provider-based compliance via our provider-based attestation. My suggestion is to all of you is to have your provider-based attestation at the ready. That way, whenever you're asked to reattest, you won't have a problem. When we submit the attestation, the attestation is required because there's a significant difference in payment from Medicare. There's not going to be a difference in beneficiary liability. There's a substantial difference in Medicare payment. So since there's a difference, we have an attestation required. If we've been billing as provider-based and Medicare sends you a letter and says, okay, go ahead and reattest, you generally will have 10 days to reattest. And at that point, if that attestation is rejected, all of your provider-based money, the difference between you being a provider-based and a freestanding, will be recouped. So we don't want to mess with that. So I have everyone have their provider-based attestation at the ready. So we don't want to mess around, and in 10 days is not going to be a great window to get your compliance corrected if for whatever reason you found yourself to be out of compliance. It's part of our purpose here today. Now, in addition, the Office for Civil Rights, we used to be able to get away with, we used to be able to do our OCR compliance just at the hospital level. At this point, and particularly if you're doing a new provider-based clinic, we're going to have OCR compliance at the clinic level. So that means all your OCR policies, and your OCR policies are all of the things for that have to do with non-English proficiency, hearing impaired, sight impaired, and non-discrimination. So, for example, all of your translator mechanisms and policies you got to have in the clinic name. I know it's a pain, but that's what you got to do. So all of your hospital should have OCR policies, and you need to duplicate all of your OCR policies and those mechanisms for hearing impaired, sight impaired, non-English language proficiency, and non-discrimination. Those should really be at each clinic that the hospital owns. You're going to have that OCR compliance. Again, our on-site provider-based clinic is 250 yards of the main building. On an individual basis, CMS can determine whether or not something is part of the provider-based campus, but for general terms, they use that 250 yards to determine that. Now, I want to be sure and leave some time for questions. So particularly when we get down to obligations of hospital outpatient departments, I'm going to skim over that pretty quickly because that's the OCR stuff we just talked about in a lot of ways. But at any rate, I want to leave some time for questions. And so I want to get through these criteria, and then we'll wrap this up, and I'll make sure that we're able to answer any questions that you all will have. So that A03030, or the 42 CFR 41365, really breaks down the provider-based compliance components into these 6 areas or 7 areas, depending on how you count a couple of these. So licensure, how your clinical services are organized, the degree to which it's integrated with the parent, what the public thinks you are, who the public thinks you are. Then we've got all of our non-discriminatory compliance things that are our obligations of hospital outpatient departments. And then we have some joint venture considerations. So our licensure, for example, the first thing is that we have to be, as a provider-based rural health clinic, we have to be appropriately licensed in our state. So obviously in Indiana, we would have to have a clinic license if that were required in Indiana, which it is not. Indiana does not require a separate provider license, a separate clinic license. Kentucky requires one, Louisiana requires one, but to my knowledge, maybe California, but otherwise, no states that I know of here in the Midwest specifically require that license, clinic license, and I'm fairly certain that Indiana does not either. But the clinic would certainly have to meet all the appropriate licensure requirements, building safety, fire codes, et cetera, for the locality, for the entity, and obviously to keep patients and employees safe. So we would document our licensure by providing a copy of the 855A, copy of our current state license, or a statement of from someone at the state saying that the license is not required for a provider-based facility. Just for the record, I'll hold off on that for a second. So in order to map the distance between the main provider and the facility, we're gonna provide a map. We're gonna have a description of the physical facility and where it resides from the provider-based facility. So that documentation, all of this format is generally laid out in a provider-based attestation format that the MAC may have on. I'm really going through and describing the components of the compliance. So these may be confirmed and documented in various forms depending on who is your MAC. So if you have CGS for a MAC, they probably have one form. If you have NGS for a MAC, they have another form. And so your MAC is going to have a little bit different process for each, depending who they are. but it's all going to contain versions of these questions. We're going to document, or we're going to show a map, we're going to show a Google map from how far we are from the main hospital entrance. Now, our clinical services, in general, all have to be fully integrated with the parent facility. So our professional staff have to have clinical privileges at the parent entity. We have all the same monitoring of our professional staff, our professional clinical staff, as do other departments. The medical director of our clinic, maybe in your town, the medical director of the clinic is also the chief of staff of the hospital, but they maintain the same reporting relationship as any other provider within that medical staff. And then they have the same committee assignments and QA activity, utilization review, et cetera, at the clinic, and the professional staff would be integrated at the hospital for all of those activities. I think that's fairly straightforward, fair. Now, our medical records, this is a common misperception. Our medical records, we have to have a unified system of retrieval or cross-reference. We don't have to have everyone on the same system. It's the same with our financial accounting. We don't have to have everybody on the same practice management system as the hospital. Oftentimes, our hospital practice management systems really stink when we try to apply them to the clinic and vice versa. So you don't have to, for example, if the hospital's on Epic, I'm sure it's in your financial benefit to be that the clinic is on Epic. But for example, in our shop, we use a Prima. We're an electronic health record and a billing company. We use a Prima in a lot of our provider-based hospitals. Our stuff is handled much better on a clinic system than on the hospital system. So as long as the hospital personnel can have a unified system of retrieval where they can get clinic records and vice versa, clinic personnel can get hospital records, you can be on different systems. That's no issue. Here's what we're going to use to document our clinical services for our provider-based attestation. And again, we'll start with, you go out to your Mac and pull your own attestation. But generally, we're going to look for key personnel, key professional staff at the facility and the names of the employer. We're going to look for an organizational chart. We're going to look at their clinic privileges at the main provider. We want to look at a documentation and some policies on what the level of monitoring and oversight is. And of course, we want to see some minutes, and we want to see some activity from there. We would need to have a description of some sort of how the medical director at our provider-based rural health clinic reports to the main provider and their medical staff and what that relationship is. And then lastly, we want to be sure that all of our inpatient outpatient services at the facility are integrated with our main provider, and all of our patients have full access to the services of our main provider. We've already really covered this unified system of retrieval. We have to have a written policy that shows how our medical records are integrated with the main provider and how we get records from one another. On the financial operation piece, really what it is that the clinic has to be fully integrated into the accounting and financial reporting system of the hospital. So it's very difficult to have provider-based clinic status when there's a separate clinic corp, especially if you're a large hospital organization with national presence. Often that clinic corp goes all the way up to the top, and there's no real direct reporting relationship on a daily basis to the hospital. But regardless, on the financial integration, the clinic has to be in effect on the GL, shared income and expenses between the main provider and the facility. And we're going to do that by reporting the clinic as a cost center of the provider, and that the clinic, the provider-based facility, is reported in an appropriate cost center of the main provider, and we can readily identify the provider-based facility. That's how we get out of that outpatient department or provider-based facility or organization. We want to show and document that cost center is readily identified in the main provider's trial balance. So it can't be mysterious. Here's the cost center for Rural Health Clinic 1. It's readily identifiable on that trial balance. So we're just going to show our trial balance, and we can clearly identify the cost center for the Rural Health Clinic. And we're going to show on the cost report, document the clear integration of expenses for the provider-based facility. And again, easily identified as a cost center. The other issue is that we're automatically going to enroll, and we have to do this on the Medicare 855, is the clinic will be enrolled using the hospital's tax ID number. So there's not an inherent requirement that's stated anywhere, but it is an expectation on the enrollment form itself. This is probably, when I talk about public awareness, the biggest thing that prevents us from being able to just go out and get our attestation fixed. If we have a problem, we really have to make it clear to everyone that they've entered an entity of the main provider, so that they know when they come in, clear to the public, that they've come into ABC Rural Health Clinic, which is owned by ABC Hospital in ABCville, Indiana. So that what we would do is all of our letterhead, yellow pages, website signs, advertisement, registration forms, we want our logo with our ABC clinic, a part of ABC Hospital, or a part of ABC Memorial Hospital, or a facility owned by, but we want it very clear. A lot of times it's ABC Hospital Clinic. And even in the time, you know, on this one, I like to be as conservative as we can. And even if your name is ABC Hospital Clinic, I still like to tack on there a part of ABC Hospital, just because I can't sleep unless I know our client provider-based compliance is straight, and that there's not going to be a threat of some problem there. Now, our hospital obligations are evidenced by our EMTALA policy, our anti-dumping rules, our support services furnished at the physician, so that we're billing with the correct site of service. So just a couple of things that I want to say about those things. We have documentation that the facility complies with the hospital provider agreement. So we have to be able to show that we're in compliance with the hospital provider agreement, that our non-discrimination provisions, the CFR 48910, that's actually a rural health non-discrimination, but that we've got those in evidence, our OCR policies, and the hospital non-discrimination policy for employment or for our patients. We don't discriminate for any reason against patients. And all of our Medicare patients are treated as hospital outpatients, not as physician office patients, but put a major asterisk on that, because we're not treated as hospital outpatients. We're treated as rural health clinics. So absolutely, we're a rural health clinic all day long, and I'm going to talk about that place of service here in a second. And ultimately, our payment window provision does not apply to rural health clinics. We don't dump our more expensive patients out of the rural health clinic and on somebody else, so we have anti-dumping compliance. And here's what I want to say. We're short on time here, so I want to get through these requirements and leave a few minutes for questions. But that place of service question comes up frequently. So I'm color-coded here. Green is good, in this case black is neutral, and red is bad. In my view, when I go and ask CMS, hey, what place of service do I have to use as a provider-based rural health clinic? And when I've done that, they send me the place of service listing. So of course that frees us up to pick which one is most relevant. As a rural health clinic, we saw in 41365A2 that we're not a hospital outpatient department. So place of service 22 does not apply to us. If we want to have a compliance and coding argument, we're place of service 72 all day long. I argue that because we're not an outpatient department, we probably still bill place of service 11. And frankly, it doesn't matter to us, because we all know there's not a place of service indicator on our UB in the first place. So the issue becomes what happens on all of our commercial claims and on our non-rural health clinic claims, et cetera, et cetera. And I am of the mind, absolutely, that even on the commercial claims, we are not a place of service 22. Absolutely not. And so I would run fearfully from place of service 22 in your rural health clinics, or place of service 19, because place of service 19 is a satellite department of the hospital. We are none of those. If you bill your commercial claims with place of service 22, all of that is going to go to the patient hospital deductible, and you're going to make all of your patients very angry. I've been through that with a client that made that decision against our advice, and they spent 2 years dealing with it. And then their billing department would not change it without written documentation, and nobody was willing to provide the written documentation. So my point is, we're our place of service 72. We're not a hospital outpatient department. We're a rural health clinic, so our correct site of service is place of service 72. We can argue that all day, every day. I'm going to breeze over our non-discrimination stuff. So these are all of the requirements of the OCR that we just talked about. So you can go through these slides. Your hospital is going to have these set up in the first place. You've got your health and safety rules at the hospital. So the hospital has EMTALA policies in place, but here's the trick. So here's another bit of a misdirection. We have to follow our EMTALA policies if we're an outpatient department of the hospital. We're not an outpatient department of the hospital. We're a rural health clinic. I think I've said it before. So our health and safety rules are relevant for us as a rural health clinic. As a rural health clinic, you have a sample kit of medications in an emergency drug supply for those drugs and supplies commonly used in a physician. So you have your own emergency supplies. Your provider-based rural health clinic is subject to your rural health clinic emergency policies. We're not subject to EMTALA. So we do not have to triage patients in our rural health clinic like the ER does. We triage our patients according to our rural health clinic policies. So again, we can have a broader discussion about that, but the end result is your provider-based rural health clinic is not subject to the larger EMTALA provision. Now, some of our provisions for offsite are, as I mentioned, are different than the on-site stuff. So first of all, an offsite, whoever we're attesting, so if we're attesting that ABC Hospital Clinic is part of ABC Hospital, then ABC Hospital has to own 100% of that offsite location. So we can't have a joint venture with proportions of ownership at the offsite facility. Offsite facility has to be 100% owned by the main provider. Offsite facility has to have the same governing body and sets of documents and policies, just like we talked about all the reporting relationships, et cetera, as any other outpatient department at the offsite location. So we have the same management and control. At the offsite location, we have to have the main provider has final responsibility for all decisions made relative to that clinic and for final approval of all medical staff appointments. We've got these various people that we're going to have as administration and supervision, and how we're going to document these things. And again, it's the same thing that we did with the medical staff. What are the key administrative staff and to whom do they report? What's our organizational chart and to whom at the main provider does the provider-based facility report? We have here the facility directors, here's how often they report, here their accountability for day-to-day operations, and what administrative functions are integrated with the main provider, billing, et cetera, and are there administrative functions that are outsourced? So again, we've got the same ownership and control as the parent entity, and I think we've been through most of those things. Now, our distance requirement, we have a distance requirement, but again, if we have a hospital of fewer than 50 beds to whom we are attached, we're not subject to the location requirements of this. So that's how to translate this. We're not subject to the location requirements under this section. And let's see, I got my drawer is not working there. There we go. So we are not subject to the location requirement of A03030. That's the program memorandum we're talking about. So the distance requirement is 35 miles unless we're a rural health clinic attached to a hospital of fewer than 50 beds. So in short, our distance requirement is waived as a rural health clinic as long as we're associated with a hospital of fewer than 50 beds. So excuse me. I cannot get us to change. There we go. So joint ventures at our offsite location. In effect, we can't have a joint venture at an offsite location. So the joint venture is the clinic. So let's say that ABC Hospital owns 50% of the rural health clinic, and that XYZ Hospital owns the other 50% of the rural health clinic. And the rural health clinic is 30 miles away from the main provider. If the off-site rural health clinic is jointly purchased or jointly created, and the facility is not located on the campus of the main provider, we don't have provider-based status. So what this is saying is our off-site clinic cannot be jointly owned. A clinic on campus could be jointly owned. I don't know when that would happen. But by extension, if the main provider, let's say your main hospital, ABC Hospital, is owned by Quorum and CHS together, that's fine. The joint venture at the hospital level, it's no problem. Say the rural health clinic that is off-site 30 miles away from ABC Hospital is owned by Quorum and CHS, that's not fine. So the off-site clinic has to be owned by the main provider. The main provider can be jointly owned, but not the off-site clinic. And then finally, a really important function to take away here is in addition to my drawing that I now need to get removed, is that leased employees are fine, but we have a parameter that only people who can be paid for their services under a Medicare fee schedule, under separate programs, only people that can get their own provider number can be leased, is what this is saying. So the main provider employs the staff of the facility directly involved in the delivery of patient care, except for those who can be otherwise paid under a fee schedule. So what that is saying is the fact that then I have a tough time getting back to my pointer on this. Sorry. And then there we go. So our providers and staff, not directly involved in patient care, are required to be employees. So nurses, administrative staff, all those folks cannot get their own provider numbers. So we can only lease employees that can get a provider number. So for example, I can have a service agreement with a local physician group to provide the physician services for my off-site provider-based clinic. But I can't have a management company come in and directly employ all of the staff in my rural health clinic, including the providers, and just would do a turnkey operation for that MSO. So the old MSO model doesn't work. A contracted services for the physicians, where the nurses and the front end staff are all employed by the main provider, that works. Contracted services with main provider and a physician group. But wholesale, all of the employees are leased in that organization, and it's an MSO arrangement. It doesn't really work. So I know I got through a big chunk of that at the end there fairly quickly. I wanted to hit the high points of that provider-based compliance. Again, if you go Google CMS A03030, you'll get that document that I've been going through. Now, last night I did this with Texas, and they're down in Novitas. if you want to go to your MAC and look for their provider-based attestation, go to the Audit and Reimbursement Department under Part A. If you all want to, you're welcome to email me, and I can help get you to the correct website or the correct attestation document if you want to start looking through those. Here's your Office for Civil Rights. All of those templates you can pull directly down. We just use the OCR templates and then plug in the various mechanisms that a hospital may utilize for hearing, vision impaired, non-English language proficiency, etc. But then the full CFR for what I talked about for provider-based regs is at that 41365 there. I also encourage you to look at eCFR. If you're ever Googling CFR documentation, always go for the 42 eCFR 41365. That'll give you the electronic code of federal regulations, and you have less risk of getting obsolete material out of there. So don't hesitate to contact me here. My email here is cjamesjr@northamericanhms.com. I got too many versions of this presentation out there. So that is the content of my presentation today. I think we've got 6 or 8 minutes left for some questions. So I'd be happy to open it up. Let's see.
Yeah, absolutely.
So there we go.
Like I say, I haven't received any through the chat function yet, Charles, but if anybody would like to unmute their line and ask a question, they certainly can. I do ask everyone that hasn't yet to please take just a minute, either through the chat function or if you're not on your computer, if you're only over your phone, please let me know your email address and your name. We have to keep pretty detailed records to submit for the grant that helps provide these free programs. We're unable to provide free programs if we don't get the grants, and we don't get the grants if we don't have good outcomes and data keeping measures. So if you could all share your email addresses with me, there is like a 1 to 2 minute post survey that we'll send out, and we really appreciate everybody participating in that. I do see that a question came in there, Charles, in the chat function. If a rural health clinic has a high reimbursement rate, does that necessarily mean that the productivity is poor?
So it doesn't necessarily, but so for example, when I said a high reimbursement rate, I really meant something that's well north of $250. I think anywhere up to 250 or so is a fairly reasonable average. Or is a fairly reasonable rate. When you start to get up over that into the really astronomical rates is really what I was talking about. When you get up into a $300, $350 rate, $400, $500, I've seen $500 rates, then those are the levels of rates that I'm talking about. So first of all, let's make sure what I mean by a high rate, and that's what I mean, something north of $250, even $300. So, but even so, let's say your rate came out to $280. I mean, it is what it is. It's the rate comes out, the cost report you plug in all the numbers, get all your expenses in there, and the rate is what it is. But that being said, yes, if you have an exorbitant rate, you probably have providers who are not seeing a lot of patients that are costly. So then the second question I saw on there was on the place of service. What I said is that place of service 72, yes, is really the correct place of service. I would use place of service 72 in place of 11 or place of service 22 on any of my commercial or Medicare non-rural health service claims. So anywhere that has a place of service on it, I would use place of service 72 where possible. If you have a choice, my point was I'd almost, and it's particularly on a commercial claim, because at this point it's probably a commercial claim you're dealing with, I'd rather submit a claim with place of service 11 on it than 22. Because on 22, it's not accurate. We're not an outpatient department of the hospital. But then the ramification of that, if you bill on place of service 22, is that all of your patient deductible is going to go to a hospital deductible, and you're going to have a major PR problem on top of it not being correct. So I see people really digging their heels on that place of service thing. We're outpatient department of the hospital, we're place of service 22. No, we're not. We're absolutely not. Anybody arguing that to me, let's get on a conference call together, and I'll be happy to walk through that.
Anybody else? Questions, comments?
Well, either I did a really bad job or we've just answered all of the questions. So probably somewhere in between. We answered all the questions that people want to publicly post.
Well, you can send those questions privately as well to either myself or to Charles. He did share his contact information. I will share my contact information in the chat function right now if anybody has any questions they'd like to follow up with. In the meantime, I will be sending out that link for the post survey to everybody that shared their email addresses with me. It's a very quick survey. We greatly appreciate your participation. And one more big thank you, Charles, for being here today. We do appreciate it. We'll have this program posted in the next week or so on our IRHA YouTube channel if anybody needs to go back and take a peek at it or wants to share it with somebody. So thank you very much.